Hello, everybody. Welcome again to another edition of the MCHD Paramedic Podcast. This is Dr. Casey Patrick, and joining us today is our Division Chief of Clinical, Nick Smith.
Hello, everyone.
And we are going to hit on updates surrounding one of the more harrowing topics that we have in emergency medicine for me, and definitely in EMS for Chief Smith and all of you medics that are listening out there in the field, and that is obstetric updates and what we do with obstetric emergencies. Everything emergently can be scary, but obstetrics are some of the worst. They're the mountaintop, the peak. They're not quite as common, so they're rare. They often involve critically ill, younger, healthier female patients, which makes it even worse. And then you throw on a neonate that may or may not be well as a cherry on top, potentially premature even. What a mess. So luckily we have some new consensus guidelines to discuss. These were released earlier this year in 2025. So let's get started. Where did these consensus statements come from, Nick, and why is this a big deal?
Yeah, so this is actually kind of cool. It's really a true cross-specialty collaboration, which is unfortunately all too rare, in the context of EMS. This was a collaboration between NAMSP, ACOG, the NAEMT, and the Paramedic Foundation. It was released earlier this year. The consensus statements, we'll have the link in the show notes for our listeners. Just a little disclaimer here, I have to throw this out. This is not a strict MCHD protocol discussion. This is us discussing the consensus statements. So there may be a few clarifying moments throughout the podcast for our listeners, both on the MCHD side and not, but something to keep in mind regardless. So with that, how about we jump in first and foremost into something that you mentioned, that obstetrics, natal care, all of those things that make us really want to lean on that seek expert consultation guideline, make us all want to go there. Can you talk first about postpartum hemorrhage and some of the recommendations there, maybe a little bit of background on it as well?
So when I say postpartum hemorrhage, I may abbreviate that as PPH. So if you hear PPH, postpartum hemorrhage, to say what Chief Smith said a little more clearly, we're not changing any MCHD protocols today. You may hear some different doses or some different orders or some different approaches. No protocol changes today. And just to hit on one point from Chief Smith's intro, the EMS physicians, NAMSP, the American College of Obstetrics and Gynecology, ACOG, the NAMT folks, the Paramedic Foundation, so medic representation, so EMS medical directors, obstetricians, and paramedics are who got in the room and wrote these recommendations together. Cross-specialty collaboration. Pretty wild, doesn't happen very often. But this is big for me as the EMS medical director, because when we get calls from the hospital and calls from the OBGYN, these are their people in the room with us making the determinations in the order and the emphasis in these guidelines. There were 3 guidelines. There was one for postpartum hemorrhage. There was one for eclampsia, and there's one for hypertension in pregnancy. So they were separated into 3 separate guidelines. We're going to speak of them as if they were one, because honestly, I would just save those 3 PDFs together and file them away. One of the other things before I get into PPH that was really excellent about these is they're not a manuscript style. They're truly written as guidelines. And, most of us out there, when we read journal articles, we're asleep before we get through the abstract. These really are the high points. So I would encourage you actually to go access these guidelines and save them, read them, make mental notes, because you can actually do that with these. So let's roll into postpartum hemorrhage, or PPH. There are 2 types that are defined: immediate and delayed. Immediate is within 24 hours of delivery. Delayed can occur up to 12 weeks postpartum. I'll be honest with you, I wouldn't have thought delayed PPH can happen 1, 2, or 3 months after delivery, but it can. So that was something that I learned from these guidelines. So immediate postpartum hemorrhage, less than 24 hours, delayed up to 12 weeks postpartum. This is delivery-related bleeding, not traumatic bleeding. That's an important point. And the definition here, which if I have one bone to pick in all of these, this might be my single little tiny little bone. Definition of postpartum hemorrhage within these guidelines is greater than 1 liter of blood loss. Now, I'll take the medical director stance here. How do we put that into a protocol, Chief? And I don't know how we're going to do that. We're going to have to sit and discuss, because we know that estimates of blood loss are dicey at best. What do you think?
Yeah, absolutely. I think it's very, very difficult to be able to adequately measure a liter of blood loss, any blood loss really. So I don't really think you can protocolize that. I think, again, these are recommendations, these are guidelines. It gives the provider an idea of blood loss, but there's no true way to measure this. I know there's really no way that we can capture that blood in any sort of measurable standard.
So my gut feeling right now is this may end up being severe bleeding associated with postpartum hemorrhage, immediate postpartum hemorrhage, or delayed less than 24 hours, or up to 12 weeks. And it's just going to be a judgment call, but we'll see where that comes out in our protocols. Like we said, no protocol changes today. What are the recommendations? Well, these are probably a little bit shocking in that some of these things aren't typically thought of as EMS medications, really. We start, though, with one that is commonly taught from day one of medic school, and that is everyone in this situation, if you have immediate or delayed PPH, you get fundal massage. So that's number one. That shouldn't be a surprise to anyone. Number two shouldn't be a surprise either. Close monitoring and early IV or IO access. That's standard in someone who is hemorrhaging. This is not traumatic bleeding, but if there is visible laceration, the recommendations are to apply pressure. That makes sense. We apply pressure to external bleeding all the time. That's standard of care. They did make note, and I think this is reasonable to think about and to educate on, and that is we're not putting anything inside the vagina here. And I agree with that. So nothing inside the vagina. Now, if you do those three things and we still have bleeding, the next step is oxytocin, trade name Pitocin, 10 units IM, or in a 500 cc bag given IV. So that's med number one. Med number two is misoprostol, 600 to 1,000 micrograms. That can be given several different ways. We do that in the emergency department, usually with OB guidance. I don't know that I've seen it in EMS protocols anywhere, but it can be given orally. It can be given both swallowed or sublingual, and also rectally. They also make mention to consider blood. And that's going to depend on whether or not your service carries blood products, whole blood, PRBCs, plasma, probably all in the mix there as far as the recommendations would go. And then we move to one that we're very familiar with here at MCHD, and that is tranexamic acid, or TXA. And the key point here, and this holds true for our other TXA indications, is that it is for immediate postpartum hemorrhage only, not for the delayed variety. And that fits with the fact that we know in trauma that TXA is beneficial when given early. The earlier the better, in fact, which is why we've switched to saying around here that TXA is a pre-hospital drug, even more than it is an emergency department drug, because the earlier the better. We do not want to give TXA to a delayed postpartum hemorrhage at 4 weeks or at 8 weeks. That's going to be not helpful and potentially harmful. Their recommendation on dosing was oddly specific. I believe this comes from a difference in the OB literature and the trauma literature, but they did not recommend the trauma 2-gram dose. They recommended 1 gram and then 1 gram given over 30 minutes. So that's sort of the older way that we dosed our TXA in trauma until moving to the 2-gram dose. So 1 gram, then a 1 gram bolus. Let's talk about oxytocin and misoprostol just a bit. Those are some less familiar drugs, at least to our MCHD listeners. Oxytocin is a naturally occurring hormone. It's used to induce uterine contraction. So that's good if we want to induce labor, if we want the uterus to contract and push the baby out. So if folks are struggling to labor, they get put on an oxytocin or a Pitocin drip. The uterus contracts, baby comes out. If the baby's already delivered and we have excessive bleeding or postpartum hemorrhage, then we give that Pitocin to contract the uterus on itself to basically create a natural tamponade. Misoprostol, on the other hand, is a prostaglandin E1 analog. Yes, I had to look that up. I did not remember that from medical school. That's the second time in my life I've learned this. And it is also a uterotonic, or increases uterine contraction. And in the same way that oxytocin causes the uterus to clamp down and to stop bleeding, misoprostol is sort of a double whammy, and through the prostaglandin route, causes uterine contraction and decreased bleeding. So there's your postpartum hemorrhage overview. The guideline is really succinct and straightforward. Take a read. So let's switch from postpartum hemorrhage to seizures. Also, when you think about things that can scare your pants off, seizures are another, especially when you have a pregnant mother seizing. So talk to us, Nick, about the eclampsia guideline and how it's defined, what some of the recommendations are.
Yeah, so starting off with sort of the definitions here. So eclampsia is seizure during or up to 6 weeks postpartum without other causes identified. Interestingly enough, the guideline here references that this patient may not be hypertensive. So I know historically in EMS, certainly in paramedic school and paramedic schools across the state, the nation, they've talked a lot about how once you hit that 140/90 number and they're hypertensive and they're going to seize and then they're eclamptic, that hypertensive patient or that hypertensive presentation may or may not be there. This is a time-sensitive emergency. You absolutely want to be quick treating this. And they did give some recommendations. So recovery position for the patient, we're going to make sure that they're left lateral decubitus. Obviously, just like with any other patient in seizure presentation, close monitoring and access, IV or IO. You want to make sure that you're carefully monitoring the airway, prepping to manage as needed, having your suction out, your BVM by your side, and intervening appropriately, potentially BVM on the patient if you need to address that quickly. Their recommendation, again, just pause for preface for the MCHD folks. This is the recommendation. Our protocols still stand as they are now. Magnesium, first line is their recommendation, 4 grams IV, then 2 grams over an hour, or 10 grams IM, be 5 grams in each side in each gluteus. This is for treating the patient if their BP is presenting as greater than 160 over 110 diastolic.
The last piece about blood pressure that I think is worth mentioning is that they make a comment about only treating the blood pressure if it's greater than 160 over 110. So we can tease out a little bit where this differs from our MCHD teaching if you want to. And the first spot is magnesium first line. How have we taught that classically? Because that is a little bit more stringent than what we've taught.
Yeah, so I mean, classically with our patients presenting with seizure presentation, our approach has been to administer the benzo first, and then if you have the patient who is continuing to seize, you have suspicion for eclampsia or eclampsia presentation, then you follow up with the magnesium.
Yeah, my normal answer to that question is I give both. And honestly, I'm prepping to give both, trying to have dual access points, and really it's benzos and magnesium, not either or, is the way I approach it in my practice. So again, guidelines are just that, they're guidelines, and we're not changing our protocols or our teaching today. We will probably change some of these coming in Q1 of 2026. But for now, still fall back to if you have a seizing pregnant patient or that up to 6 weeks postpartum patient that we think is eclampsia, benzos and mag is generally our approach. Remember here that a key in eclampsia, and I think this is worth hitting on before we move on to the hypertension portion, eclampsia is seizures in pregnant or postpartum patients up to 6 weeks without other causes. So this isn't a head injured patient. This isn't an intoxicated or a withdrawing patient. This isn't a patient that's been on Keppra for their entire life for epilepsy. This is a patient with otherwise unprovoked and no prior seizure disorder history. That's pretty clear?
Yeah, I believe so.
And then the last piece on that blood pressure that Chief Smith mentioned, they stated to only treat the blood pressure in an eclamptic patient is if it were greater than 160 over 110. Now, you're going to be treating the blood pressure with the magnesium because that is one of our eclampsia treatments anyways. But the MAG is part of that as well. So they're basically saying if you give the MAG and it comes down to 150 over 100, then let it ride. I might disagree a little bit with that in my practice, is if we gave the MAG and it came down into 150 over 100 range, then adding some labetalol on there would still be advised. And our protocols would read that way and do read that way today. So before you start to ask that question, MCHD listeners, that's my answer. I would be a little more aggressive than the guideline at that point. Again, we're just discussing the guidelines today. So moving into hypertension and pregnancy, like eclampsia, it's a pregnant patient or up to 6 weeks postpartum. It starts at the age of viability. So this is greater than 20 weeks when we are going to apply this guideline and this diagnosis. And our cutoff, blood pressure wise, thankfully, is the same.
40 over 90.
The same as we have here. So you don't have to relearn another number, plus symptoms. And this aligns well with our MCHD protocols, thankfully. Headache, vision changes, abdominal pain are some of the examples that they give in their guidelines, and these match up pretty well with our protocols. So we'll take that as a relief, and we don't have to make a bunch of wholesale changes. Preeclampsia, hypertension and pregnancy, eclampsia, these are all time sensitive situations because the quicker you reverse them, the less likely you are to proceed into complications, whether that's an airway complication like Chief mentioned in seizures, or that's the progression to eclampsia from preeclampsia. I don't know the data. I would still suspect that most eclamptic patients are hypertensive, but I believe it's a good learning point to remember if you don't have a source for the seizure, they don't have a seizure history and they're 130 over 85, we're still treating that as eclampsia. So moving into the recommendations for hypertension and pregnancy, close monitoring, IVIO access, shocker, that's going to be similar throughout these emergent situations with obstetrics or any other emergent situation for that matter. Be prepared for a seizure oncoming. I believe we do that with our preeclampsia patients. I'm thinking about where my benzos are, how I can get those drawn up, prepped, and ready. If we've got a weight-based dose, that may be an issue depending on how your protocols are written. Here at MCHD, I'd have 10 milligrams ready to give IM or 5 milligrams ready to give IV. Who gets blood pressure treatment? So there's two questions when we deal with hypertension and pregnancy. It's who gets blood pressure treatment and who gets magnesium. And so let's start with who gets the blood pressure treatment. And again, here at MCHD, we've talked about giving both of these over time. I believe to Chief Smith's point, most of us are going to go benzos first, mag second in eclampsia. In preeclampsia, usually I'm starting with magnesium, but let's talk about the blood pressure medications first. And to get blood pressure medication treatment in these guidelines, their cutoff is 160 over 110. And that is a second number that's not in our protocols currently that's important to remember because that's the cutoff between preeclampsia and severe hypertension with preeclampsia. So there's sort of the moderate, which is 140 over 90, and the severe that's 160 over 110. And they recommend treating if the 160 over 110 persists for 15 minutes. So it's not a single number, it's a persistent severe blood pressure elevation. And they give three options: labetalol, hydralazine, and nifedipine. Now, we don't have hydralazine or nifedipine here at MCHD, so I'm not going to really belabor those two. We do have labetalol, so I think it's worth mentioning. They recommend 20 milligrams of IV labetalol, reassessing and repeating every 10 minutes with increased dosing, actually, 40, 80, up to a drip every 10 minutes. Now, luckily, we're not going to have the patients in our care that long here in Montgomery County because our scene and transport times aren't that long. So this fits pretty well with our protocol set. We're probably not going to go into hydralazine or nifedipine here at MCHD. Those are antihypertensives that are most commonly used in the obstetric world, but other options out there depending on what your service has. These recs apply to eclampsia, so that's where that 160/110 comes into play in eclampsia as well. But it brings us back. I usually start in hypertension in pregnancy and preeclampsia with magnesium. And so the magnesium piece, thankfully, matches up very well with where we are today, and that is 140/90 with symptoms in these recommendations get magnesium. They also recommend for 160/110 without symptoms to get magnesium. So that's probably worth considering in our protocols. Again, no changes today, but that's where we fall. So remember, preeclampsia and eclampsia, both time sensitive. Remember that 140/90 is your entry point, and then that 160/110 in these guidelines sort of as the severe progression. And you're often going to be doing two things at once: mag and benzos for eclampsia, mag and additional blood pressure medication for hypertension in pregnancy or preeclampsia, depending on how these things progress. So with that, Chief, we talked about some discussion points that we wanted to close with. Walk through those and let's toss them back and forth.
Yeah, so I'd say that the first thing that we should hit on is the importance of data-driven recommendations. We really do not treat OB emergencies aggressively in EMS, and having something like this where we have guidelines from a cross-collaborative, multi-group standpoint is what I think we really need more of in EMS, especially for such a important patient population in which many of our providers don't have a lot of confidence in. I know certainly even just having guidelines for me to look at and talk through these recommendations already makes me feel more comfortable in encountering these types of patients.
We often say they don't know what it's like for us in EMS, and they can be the surgeons, the cardiologists, the obstetricians, and like anything in this world, the flip side is true. We don't know what it's like for them. At least I don't. I don't know what it's like to manage these patients on the L&D unit. Now, I rotated on labor and delivery way back when. I won't tell you the date, but that's not my area of expertise. And so that is the beauty, is that both sides got in the room and looked at each other and talked about their perspectives and said, hey, this is how we should write this from what we want once we get the patient from you. And some medics, some EMS physicians said, but wait a minute, here's what we have to work with. These are pretty excellent recommendations from my standpoint. Are they perfect? No. Would I change a little bit here and there? Maybe, but not a whole lot. And realistically, they are a big step forward from what we're used to having. So to the people that worked on these, especially the National Association of EMS Physicians, that's my people, huge thanks, huge props, because these are really, really excellent and useful. The MCHD approach to this and how we will take these recommendations, meld them with our protocols and our education is coming soon. So Q1 of 2026 is the tentative goal to roll this out. Hold tight, no protocol changes today, but you won't be surprised to find in January and February of 2026 some potential changes for magnesium, for labetalol, for tranexamic acid. Those are already on the truck. Y'all are familiar with them. So we may add and subtract and edit the way those exist. For those that have been at MCHD for a while, and even when I started 10 years ago, we had Pitocin on the trucks. It might be time to reconsider that removal. So just stay tuned. More to come there. But lastly, most importantly, when we talk about preeclampsia, eclampsia, and postpartum hemorrhage, while they're all very different, they hold one thing in common, and that is they are
time sensitive. So these are the keys with OB emergencies, and really one of the major takeaways that we should have from this. I think that in general, a lot of paramedics, because of frequency, because of uncomfortability, because we haven't had clear guidelines like this to go off of beforehand, can be uncomfortable treating these patients. And I think that seeing it written out so clearly, and please do go read the PDFs. It's not a long read. It's not very labor intensive. And it really reinforces sort of what we talked about today. These are time-sensitive emergencies, and it is okay to treat these patients. It is okay to recognize that somebody is an eclampsia, maybe not with a hypertensive blood pressure, and give them the benzo and the magnesium, and look at treating blood pressure following that. I think these are great guidelines that we should read through, we should consider, and if you're an EMS service out there that hasn't had a foundation in OB before, reference these, bring it to your medical directors, your clinical teams, talk about how this could be a part of your treatment protocols.
Let's wrap it up and review the guideline one last time. Here are the high points for me. Take a look and make your own list. Postpartum hemorrhage defined in these guidelines as greater than 1 liter of blood loss. How we're going to protocolize that, TBD, but that's where we're going to start. Massage, still there for postpartum hemorrhage. Moving to oxytocin. Moving to TXA, if immediate. Remember, there are 2 types: immediate postpartum hemorrhage, less than 24 hours, greater than 24, up to 12 weeks out, delayed postpartum hemorrhage. Going to get massage, going to get oxytocin, potentially misoprostol, but no TXA for the delayed PPH. Eclampsia is unprovoked seizures in pregnancy or up to 6-week postpartum. Magnesium first line, I would say benzos in a tie as first line as well. Again, MCHD's teaching is a little bit different than the guidelines here. 2 levels of hypertension to remember from these guidelines. 140/90 will be easy for all the MCHD medics, with that severe hypertension up to 160/110. Both hypertension in pregnancy, preeclampsia, and eclampsia has the same date range, and that's 20 weeks, the age of viability, up to 6 weeks postpartum. Early magnesium, we know that we don't hit this mark. The data drives this, as Chief Smith said. When we look at patients who should have gotten magnesium in EMS for preeclampsia, for example, those that should have versus those that did, there's way too wide of a gap there. So if you're 140/90 in MCHD and you have symptoms, abdominal pain, vision change, headache, magnesium, 4 grams, not 4 milligrams. And thankfully, we made that change pretty recently here at MCHD, so we're right on line with the 4-gram IV dose. 10 grams IM, wow, that's a couple big shots. We don't have that in our protocols here, maybe to come, worthy of further discussion. Lastly, for our blood pressure management in the pregnant patients here at MCHD, we're going to concentrate on the betalol and continue to concentrate on that at that 140/90 range. How we add 160/110, we'll see. Don't expect hydralazine or a nifedipine anytime soon here at MCHD. But for example, nifedipine can be given orally. That's an option out there depending on the austere environment in which you practice. Could potentially even be an EMT medication. Who knows? For those of you out there who are thinking about scope of practice and giving oral medications. But that's another topic for another day. So before we wrap up, Chief Smith, anything you want to add?
No, again, just please take the time to review the PDFs that are linked in the show notes. This is a very important patient population. Reading this will make you more comfortable when you encounter these folks. If for nothing else than being able to report what you see in the field to the providers that you deliver these patients to.
No protocol changes for the MCHD listeners today. We'll close out there. As always, thank you for watching on YouTube. Thank you for listening wherever you listen out there on podcast platforms. Follow us, leave a like, leave a review. We always appreciate the comments from listeners. Ideas for future podcasts come from y'all, and we love it. Thank you for listening. Thank you for watching. If you want to send us feedback, podcast at mchd-tx.org. We'll be back with another episode soon.